Bromage scale. Welcome, Dr. Ruchi, and over to you.
Good evening, everyone. First of all, I would like to convey my sincere gratitude and thanks to the HOD Dr. MD Kaur ma'am and APPEC team to giving me the opportunity to deliver a talk in APPEC 22. Today I am going to talk about bromage scale, which is a very important topic for exam point of view. So we start with the definition. Bromage scale is the tool for the measurement of the intensity of motor blockade. The intensity of motor block is assessed by the patient's ability to move their lower extremities. Why it is important to assess motor block? To determine the amount of motor function, to ensure the patient is safe to ambulate, and to detect the onset of complications like epidural hematoma or abscess formation. Bromage scale was originally developed by Philip Rekes Bromage in 1965 to assess the recovery and regression of motor block with sensory block to S5 following administration of local anesthetic. In his score, he gave 4 points, in which grade 1 means complete paralysis, means patient is unable to move feet or knees. In grade 2, there is almost a complete block, means patient is able to move feet only. In grade 3, patient is just able to move knees. And in grade 4, patient experiences no motor blockade, means there is a full flexion of knees and feet. Several modifications of Bromage scale have been done. Modified Bromage scale was described by Logan and Wildsmith for the onset and assessment of motor block. Modified Bromage scale was categorized in 0, 1, 2 and 3 grades. In grade 0, patient experienced no motor block, means patient is able to do free movement of legs and feet. In grade 1, there is a partial block, means patient is just able to flex knees with free movement of feet. In grade 2, there is almost a complete block, means patient is unable to flex knees but free movement of feet. And in grade 3, there is a complete paralysis, means patient is not able to move legs or feet. Now, how to assess motor block? First of all, explain the procedure and purpose to patient. Ask the patient to flex their knees and ankles. The degree of motor block on both the left and right legs should be assessed separately. For children and disabled persons who are unable to follow the commands, try to elicit movements by tickling toes, gentle knee or hip flexion. For better understanding of modified Bromage scale, we made a video in which Dr. Siddharth and Dr. Dheeraj will demonstrate how to assess motor block in a stepwise manner.
Here we are demonstrating the modified Bromage scale in this patient. In grade 0, there is no motor blockade. Patient is able to raise extended leg, move his knee and move his feet. In grade 1, there is inability to raise extended leg, but the patient is able to move his knee and the patient is able to move his feet. In grade 2, there is inability to raise extended leg and patient is not able to move his knee, but patient is able to move his feet. In grade 3, there is complete motor blockage. Patient is not able to raise extended leg, patient is not able to move his knee, and patient is not able to move his feet.
Thank you, Dr. Siddharth and Dr. Dheeraj. Now coming to the next slide, which shows limitations of Bromage and modified Bromage scale in case of labor analgesia. Because it was designed to measure surgical block, while in labor analgesia, we give local anesthetic in dilute form and we need to achieve sensory blockade only. So, to overcome the limitations, Breen et al. Used a 6-point scale for the assessment of motor block in an ambulatory patients who received epidural analgesia for labor, in which 2 categories were added to modified Bromage scale. The 2 new categories were detectable weakness of hip flexion while supine and able to perform partial knee bend while standing. Now Dr. Priyanka and Dr. Dheeraj will demonstrate 6 points motor assessment scale given by Breen et al.
Demonstrating modified Bromage scale as described by Breen et al. It has 6 scores. Score 6 is patient is able to perform partial knee bend. Score 5, no detectable weakness at hip flexion while supine. Score 4, there is detectable weakness at the hip flexion. We can see that patient is not able to move his leg. Score 3, it is almost complete block. The patient is able to move his knees and feet. Score 2 is patient is able to move his feet. And score 1 is complete block. The patient is not able to move even his feet.
Now coming to the last slide of questions and answers which may be asked by the examiner in Viva session. Question number 1 is, what is the sequence of nerve block? The block occurs in a stepwise sequence with autonomic impulses blocked first, then sensory in which temperature, cold before heat, then pain, then touch, after that deep pressure, and in last proprioception, and finally motor impulses will be blocked. Question number 2 is factors affecting epidural block height. There are variety of factors which are related to epidural block height, in which first is drug-related factors are volume and dose of local anesthetic are the most important drug-related factors. 1 to 2 ml of solution should be injected per segment to be blocked. Additives such as bicarbonate and opioids influence onset, quality, and duration of analgesia and anesthesia, but these do not affect spread. Patient-related factors are age and pregnancy. Elderly patients require less volume of drug to achieve block height due to decreased compliance of epidural space and increased sensitivity of nerves in elderly. And in pregnant women, there is engorgement of epidural veins due to increased abdominal pressure. Procedure-related factor is level of injection. Question number 3 is, what does a doctor or resident assess when a patient is having epidural? Position of epidural catheter, sensory block, and motor block should be assessed by a doctor or resident intermittently. Question number 4 is, how many hours does local anesthetic drug affect wear off and how? Drug spread and removed via diffusion, vascular transport, and by leakage, and duration will be depend upon the local anesthetic which we use. Like in lignocaine, drug effect lasts up to 90 minutes, and for bupivacaine it is up to 2 to 3 hours. Thank you all for your patient listening.
Thank you, Dr. Ruchi. Very well explained. And do we have any questions in the chat box? I cannot see any question.
No, ma'am. As of now, there are questions.
So can we move to the third speaker?
Yes, ma'am. We can do that. We can just cover up the questions at the end of the session.
Okay. So our third speaker is Dr. Shipra Agarwal from VMMC, New Delhi. And she'll be taking a talk on vasopressors and inotropes. Welcome, Dr. Shipra. Over to you.